So anyway, the fact of the matter is you've got to be detailed. If you do not have, and you probably don't, hopefully you'll get it, Barbara will let us have some of her money, and we can get those nice actuarial studies of the market we're going into. I would suggest look at your, whoever is developing the exchange in your state. Most of them have taken some of that first $1 million money that most of the states got, 48, 47 of them, I forget what, and did a fairly detailed actuarial study, or we did in North Carolina. And let me just give you 30 or 40 seconds from what we found in North Carolina. First off, I'm going to do a little bit about the environment that Lindy and his colleagues are going to be facing in North Carolina in terms of the market competition. Probably like some of you, we have, I'll refer to it as Snow Blue and the Seven Dwarfs. I won't say which one was sleepy. I had a few when I was a regulator that I called sleazy, but that's another issue entirely. Snow Blue and the Seven Dwarfs. The dominant carrier, 80% of the non-group, 65% of the small group. They have a most favored nation status. We've got it off the books legislatively this year, but the reality is it operates at 10 to 12% on the hospital side. It allows them to subsidize some things in some of the physician areas where they would like not to be. They have relations with 85% of the agent producers in the state. And oh yeah, by the way, for those producers, those agents, who in fact agree to offer their non-group product exclusively, there's a higher commission. That's tough competition. Let's talk a little bit about the marketplace. Good news is in North Carolina we're going to have about 1.2 million people who are going to be getting coverage under ACA in 2014. Half of that, a little better than half, is going to be Medicaid. Another 100,000 is large employer lives, not traditionally what we associate as our first target. Of the 600,000 lives that we expect to be insured through the exchange, 50,000 are the small employer. And Terry, I know that's one that you're going to be drilling in on. I hope that one is simply the very conservative actuarial estimate, because I labor too long in that small employer purchasing for this not to have more numbers than that. Out of the 650,000 non-group lives that will be served by the exchange by the end of 2014 or early 2015, half already have insurance coverage. What gives you the right to think that they're going to make any different decisions when they go over to get that subsidized? They're probably going to get a plan if they can't trade up because they need it, or they're going to get a plan probably with the same carrier or as close to like what they have now when they move over there to get that tax subsidy, tax subsidized premium. So that's going to be a hard nut to crack. Let's take the other 300,000 lives. The same question is asked, and this is the reason I keep talking about marketing, getting your name out, developing that niche, developing that you have a unique provider network, that you have a unique way of treating customers, whatever it is, you've got to distinguish yourself. The 300,000 lives that are not currently insured, all of a sudden are going to be able to maybe afford it. Why are they going to make a decision any differently from the 80% non-group that are currently with the dominant carrier? I don't know, but that's the nexus of what we have to be about. The one other thing is you think about it in terms of knowing your market, the market that you're going to be enrolling. Whether those new lives, previously uninsured, most of them assume that they're going to be lower cost. I'm not sure I do. Probably depends upon what have been the underwriting practices and the pricing practices and how long community rating has gone in your state as to whether those folks may have been heavily underwritten, in which case they may be a little healthier than some of the folks that are uninsured. A lot of your dominant carriers would suggest that, in fact, people who have already gotten non-group coverage are people who have a reason to have coverage, i.e. they think they are a little worse off or a little more insecure maybe than the average population. So what assumptions are you making about that new business coming in? Small group or the study we had done in North Carolina, we tried to get Milliman to do an approximation as to where they're going to come in, and there was about a 1/10% difference in their expectancy. their risk, and that can sink you in a hurry. So try to know that market. Back to that. Quickly moving, one other thing to think about. Most of these folks who have not been insured before are going to be a very expensive group of folks to service. Even if their risks are the same, the servicing is going to be more expensive. Why? How health literate are they? Do they know what a 125 plan is? Do they know what, in fact, an annual deductible is? Some of them leave them, they don't. So you're going to have to, your ability to service that, whether it's you or whether it's through the exchange or some combination thereof, or through your agent producer network if you're having one of those, or your navigator network, you've got to, in fact, bring that into your calculation. Not only that, and this goes back to my painful days in the mid-'80s in HMO development, what we found when we brought HMOs into an area that did not, that were traditionally were $100 deductible indemnity plans, once you removed the barrier for that primary care, for that annual physical and going to the doctor, you got a surge in demand. And what benefits cannot have the copays or not subject to the copays and the deductibles in the new design? All I'm suggesting is that I hope I'm wrong, that we're going to have, in all likelihood, a likely surge in what I call front-end demand. Are these any worse lives, any worse risk? Probably not over a 5-year period of time or 7 years, but there's going to be a surge. And are you capitalized? Have you built that into your predictions? Let me quickly, in the interest of time before Jerry gets up and says he knew better than to let somebody lead off from government, probably the most critical thing is, in fact, the teammate that you choose in your provider. If there was anything, and Terry and Barbara can, I'm sure will reinforce it, if there's anything our co-op advisory board was unanimous on, was the importance of that provider relationship. And let me just quickly say, if you're dusting off your old participating provider network agreement and putting that in front of them and thinking that's how you're going to get the business done, it ain't going to happen. It better be a provider partner who shares at least some of that mission, vision, values, and passion with you, and really wants to do things differently. Steve was talking about that this morning, and who is willing to undertake something differently. I would suggest that at a minimum, that your provider relationship fall into one of 4 categories: a true enterprise partner who really wants the partner to the enterprise to succeed as opposed to maybe each individual. The second would be at risk, and not just at risk economically. I would argue at risk reputationally. Do they have their name on that letterhead right beside you? Are they willing to put their names, or maybe are they willing to, in fact, advertise for you? I said advertise, Barbara, I didn't say market. I'm sure I'm making her very uncomfortable. Thirdly, might be an incentivized performance. That's sort of the gain sharing side that's sort of commonplace now. And then the fourth, if it is down to discounts, if that's all the relationship you've got that you can get at this point in time in the market, and that's not atypical of a lot of marketplaces. All I'm saying, it had better be the best of breed. It had better be right up there with the most favored nation status in terms of discount. Otherwise, I don't think you'll be able to make it economically in a competition. And keep in mind, the market you're going after, those uninsured lives, those exchange lives, those up to 400% of poverty, are notoriously the most price-sensitive folks in the business, as are, and Terry will tell you, value seekers, as are the small employer, the shop business. The other hurdle is how you deal with the agents, navigators. But I'm going to leave that aside. I think Terry will probably speak to the importance of agents, particularly with the small employer. Let me just quickly say, agents, a good agent does a lot more, does some HR stuff, does some certainly consumer complaints, even some individual counseling, even a little provider placement from time to time. Some of those you can probably do as an inherent part of, I think, the value of the organization that you're building. Some, it may be that you may want to put pressure and have the exchange do so that you can offload those, maybe such as administering a Flex 125 program. So give that some thought. But certainly the last thing I went to the North Carolina Association of Health Underwriters made the mistake of inviting me back after 15 years of being out of a regulator. And by the way, Jerry, they would defy that anybody could get to the left of me, and you did. I asked them, they were all concerned about the navigators. And they want to have navigators licensed in North Carolina, just as if an agent would. And of course, that's basically trying to close the door. And I asked them, how many of you, North Carolina is the second fastest growing Hispanic population, Latino population of any state. And I asked them how many could speak Spanish. Out of 400 some people, I had one. I asked, if you're worried about navigators, how many of you are reaching out and making your contact now, developing contacts with community-based organizations? Not a one. And I said, you know, you guys remind me a little bit of the physicians when the term physician assistants came online, and everybody's, oh God, can't have that, can't have all sorts of happening. Well, let me tell you, 20-some years later, the most prevalent means for a lot of people to getting health care is a physician assistant. They're very happy with it. So I think there's plenty of room in that space. God knows there's a void of the information that we're all going to need to be intelligent choosers of health care coverage, and choosers of health care. So I think there's a lot of work that can be done there, and if we can just get beyond the sort of reaction, let's keep the door closed. Let me just simply say that in closing, and there are other, certainly society's backing and getting the Fed approval and the business plan on that. I'll leave that to Barbara. Let me just say as a personal hope that I hope to follow many of you individually and certainly collectively in the coming years. I hope you will not only handle these hurdles, but hit that deadline running and run well beyond that so that you do have great results in 2014 and 2015 and well beyond. Because quite honestly, folks, our healthcare system needs it, and our country needs it even worse. Thank you.